And today we have the 18th series of Super Spreader Seminar Series, and we have Tanya Philippsen. Thank you everyone for joining us for this meeting. First of all, as always, we have land acknowledgement. We acknowledge the land of the OMNI-RÉUNIS Network's head office, which is located on York University. York University recognizes that many indigenous nations have long-standing relationships with territories upon which York University campuses are located that precede the establishment of York University. York University acknowledges its presence on the traditional territory of many indigenous nations. The area known as the Toronto has been taken by the Anishpac nations, the Haudenosaunee Confederacy, and Huron-Wendat. It is now home to many First Nations, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of Great First Nations. This territory is subject of the Dish and One Spoon Banquet Belt Convent, an agreement to peacefully share and care of the Great Lake regions. And about the Super Spreader Seminar Series, the OMNI-RÉUNIS Super Spreader Seminar Series, SSS, welcomes faculty members, OMNI-RÉUNIS affiliates, highly qualified personnel, including postdoctoral researchers and graduate students to showcase their research, promote their ideas, share their research experience, and establish connection among the various branches of the network. It's a platform to spread scientific knowledge about the One Health research framework and the research progress of 30+ OMNI-RÉUNIS HQPs within the network's scientific research community. These seminars facilitate knowledge exchange within the OMNI-RÉUNIS, the Emerging Infectious Disease Modeling, EIDM network, and collaborating scientific community. Today we have Tanya Philippsen as the main presenter. Thank you, Tanya, for joining us and accepting our invitation. Tanya Philippsen is an interdisciplinary PhD student at the University of Victoria under the joint supervision of Dr. Juling Ma and Dr. Matthew Little and Dr. Pauline van den Riesche. Her current research area is at the intersection of public health and mathematical modeling of infectious disease, with a particular focus on emerging and re-emerging diseases, public health policy, and the social determinants of health. She's going today to talk about a retrospective modeling analysis on the effect of control measures on SARS-CoV-2 transmission in Canada. They consider the SARS-CoV-2 pandemic between March 2020 to February 2021 in 3 Canadian regions: Vancouver, Toronto, and Calgary. This period was the period that wild type of strains occur, and that was prior to vaccination covering. They apply SEIR compartmental model to fit their data with sequential time series. Let's hear from you. Let me stop sharing. Let's hear from Tanya Philippsen. Thank you for joining us.
Okay, thank you very much. Just share my screen here. Be able to see my slides?
Yeah, thank you. It's
perfect.
Well fitted.
Perfect, thank you. All right, thank you everybody, and thank you for the invitation to speak at this seminar series. I'm really happy to be here and talk a little bit about my work, and thank you for the introduction to my project. Let's just make sure, there we go. Okay, so a quick background here, or a quick outline of what I'm going to be talking about today. We'll go through a bit of some background and some motivation for this work, particularly looking at homogeneous and heterogeneous populations, wild type SARS-CoV-2, which I'm sure we're all very familiar with, effectiveness of control measures, that sort of thing. And then I'll talk a little bit about the research objectives coming out of that background information. I'll describe the model that we've been using for this work, go through some parameter estimation processes and the results of that those activities. And then we'll look into some alternative control measure scenarios and finish up with some conclusions and next steps. So just as a little bit of a background, as we're all very familiar with coming out of the emergency phase of the SARS-CoV-2 pandemic, when novel infectious pathogens enter a very fully susceptible population with no pre-existing immunity, there are a lot of health, economic, and societal impacts, as we have seen and experienced. These novel emerging pathogens, there's a lot of uncertainty and evolving situations and knowledge. For example, who are the populations most at risk? What are the case definitions used to carry out contact tracing, testing? Who is defined as a confirmed or a probable case, suspected case, that sort of thing. Diagnostics and treatment may or may not be available or may not be widely available. There also may be uncertainties around control measure implementation, who would benefit the most from control measures and whether the control measures are effective when they're applied. And this is a big challenge to assess the effects of these interventions, particularly at the early stage of an epidemic. So there are many factors influencing the magnitude, so the number of cases, the severity, the mortality rate, health outcomes, that sort of thing, and the duration of an epidemic. So things like immunity, pre-existing immunity, vaccination coverage, transmission routes of the pathogen. So is it a vector-borne disease? Is it zoonotic? Is it human to human, waterborne, that sort of thing. Social behaviors and demographics can influence the trajectory of an epidemic as well as control measures. So some initial motivation for this work, we're going to be looking at population homogeneity and heterogeneity. So we know the typical model is the SEIR compartmental model. It's a system of ordinary differential equations that will divide up a randomly mixed population into disease-specific compartments. And this population will move through these compartments at defined rate constants per unit time. So here I'm actually showing the SEIR model, which incorporates an exposed compartment. So we have our susceptible, exposed, infectious, and recovered model. So just a little bit of a diagram because I like figures. So we have our homogeneous randomly mixed population on the left-hand side. Everybody is identical except for the disease state. On the right-hand side, we can see the flowchart of the SEIR model. So this assumption of a homogeneous population is very practical. It allows for model simplicity. However, it does ignore some differences and subpopulation characteristics that may be impacted or impact disease transmission probabilities, effectiveness of policy measures, and health outcomes. And so when using model results for a simplified model and using the results to inform policy measures may actually be more generalized than they should be and can sometimes exacerbate unintentionally the health disparities in populations most at risk for negative outcomes. So we do know that populations are really not homogeneous. There's a lot of heterogeneity in populations, and infection of susceptible individuals is really influenced by these heterogeneities and associated mixing behaviors. So again, here's another really simple figure. We have our multiple households of different sizes and compositions. Individuals will mix at different places, like at school. We've got lots of children and youth mixing, workplaces, there'll be lots of adult mixing, medical centers, personal services, and so forth. And individuals who may be infected or infectious will be mixing with susceptible individuals at these places. And so it's really important to consider this population heterogeneity in models. It allows us to have finer biological and epidemiological realism in the model and the results. which can then inform the development of more appropriate control measures and can help to identify risks of health inequities and disproportionate burdens of disease in these subpopulations. So we'll be looking particularly at the period that was dominated by the wild type or ancestral strain of SARS-CoV-2. The wild type strain appears to result in age-dependent outcomes, and we've seen this in the initial phase of the pandemic, particularly with regards to younger age groups. There appears to be more asymptomatic and mild SARS-CoV-2 infections. And there also seems to be a reduced susceptibility to this pathogen in children compared to adults. So this is not applicable to variants of concern, all of this work, just to highlight that. So this will just be associated with the wild type pathogen. So we all experienced this. Many non-pharmaceutical interventions were implemented during this time to prevent and inhibit transmission prior to vaccine availability. They were strengthened and relaxed over time, and a lot of this is due to the prevalence of cases in the province or region, resource availability, and that sort of thing. So closure of restaurants and schools, working from home, travel restrictions, things like that. And so these non-pharmaceutical interventions, when considering heterogeneity in populations, may actually impact populations differently with regards to transmission probability when you consider contact mixing between and within different groups. So what we want to look at is sort of the age-specific control measure effectiveness. So in particular, school closures was a big intervention that was applied during the first year of the pandemic. In the literature, some of the studies have found that school closures actually may not be overly effective when child and youth susceptibility to the pathogen or their infectiousness is low. Also, when community transmission is high, and if response is delayed in response to an outbreak. As well, decreasing contacts through community and school-based measures can reduce household risk when schools are open. And other studies have also found that strengthening community and adult measures, particularly in the fall 2020 period, were found to be more effective in reducing cases compared with school closures. So that leads us to the research objectives and some questions that we have. So we do want to kind of take this information from the literature and determine how generic this proposed conclusion or these findings are, that strengthening interventions for adults may have similar effects as school closures. Are there differences across regions? Does it matter when the timing of implementation? How about the impacts of other control measures on the effectiveness of these interventions? And what if there's susceptibility differences, like I mentioned earlier? And are we able to isolate the impacts of these age-specific control measures to evaluate their effectiveness on reducing transmission? So our approach is to retrospectively examine the impact of control measures on SARS-CoV-2 transmission, the wild type pathogen, between and within two age groups. So we'll be looking at children and youth from 0 to 19 years and adults aged 20 years and older. And we'll be looking at 3 urban Canadian regions between the period of March 2020 to February 2021. So the consideration for this time frame is that it is, again, primarily the wild type strain of SARS-CoV-2. So this period precedes widespread vaccination, as well as widespread variants of concern, which start to be introduced kind of at the beginning of 2021. We start in March 2020 as well, because this seems to be the period where sustained community transmission is occurring following case importation. And there are multiple non-pharmaceutical interventions, that have been implemented and relaxed over time. And so, yes, so we'll be looking at this as well. And we also do need to consider that during this period, there are a lot of uncertainties and things that change over time. So things like testing criteria and availability, capacity for case detection, and that sort of thing. So that's sort of in the background of this work that we always need to keep in mind. So here is our SEIR multi-group model. You can use a multi-group model, compartmental model, to incorporate matrices that capture between and within group mixing. So this will allow us to have more accurate disease dynamic behavior when we're considering subpopulations or heterogeneous populations. And it allows us to inform and evaluate group-specific disease control policy decisions. So this is the flowchart for our model. We have some assumptions here. We're not incorporating any asymptomatic or pre-symptomatic compartments. We do know that they are a key part of SARS-CoV-2 transmission. However, given the data that we're working with, it's primarily based on symptomatic cases and the testing criteria. So to simplify the model and also minimize the number of parameters that we need to estimate, we're going to be just incorporating or using an SEIR approach. We are incorporating the exposed class because there is a longer incubation period with SARS-CoV-2. We're also not incorporating population dynamics in this model right now, population births and deaths, and we don't include disease-related deaths, just given the time frame and the objectives of our approach. Excuse me. So here we have our, let's see, can you see my arrow? We'll give that a try. So we have our SEIR compartments, and we've divided them up into the K subgroup and A subgroup. So again, K subgroup is our children and youth aged 0 to 19, and our A subgroup is adults ages 20 and older. So each population will move through these compartments at the defined the rates. So we have our delta rate, our delta parameter, excuse me, which is the rate of becoming infectious. And then we have our gamma, which is the rate of recovery. And this alpha sub K and alpha sub A are just captured here. So this will reflect the transmission rate. And there are a couple other parameters in there as well, which I'll talk about in the next slide. Here we have these dashed arrows as well. And this is reflecting the contact mixing between populations and within populations. So for example, C sub KK will be within group mixing in children and youth, and the same for C sub AA, and that will reflect contact mixing within adults, within the adult population. And then we also have C sub KA and C sub AK, which reflects between group mixing, so between adults and children. Slide. So here we have our system of ordinary differential equations, which are representing the flowchart in the previous slide. So I did want to note that the parameters delta and gamma that we have here, they are group independent, so they're not, they're consistent across age groups, just for simplicity right now. So here on the right-hand side, we just have a table of the parameters that we're using. So again, I mentioned delta and gamma. So we have our latent period, which is 1 over delta, and 1 over gamma is our infectious period. And these values are pulled from the literature. Psi sub K, you may have noticed here, and it's part of this component here. This reflects the relative susceptibility to SARS-CoV-2 in children and youth compared to that of adults. So in the literature, we've seen that there's a varied amount, there's some various approximations of susceptibility. So we're using an estimate of 50% reduced susceptibility in children and youth compared to adults. So psi sub K will be 0.5 and psi sub A will just be 1. C is our contact matrix between and within age groups, as I showed before in the flowchart. We also do have new sub I here, and this is a parameter reflecting the importation rate. And we use this for one particular region, and I'll talk about that a little bit more. But this is also estimated from the data as well as other resources as well. And this is used in a very restricted period in our parameter estimation process. So those parameters we do know, so we pulled them from the literature and from the data. The parameters that we don't know are our beta parameter. So this is the transmission probability per contact. So that's one that we have to estimate, as well as epsilon K and epsilon A. So these are transmission reduction by control measures, representing the strength of the intervention, essentially. So these values fall within the range of 0 and 1. So when epsilon is epsilon A or epsilon K are 1, that means no control measures. So business as usual. And whenever control measures are applied, this will fall between 0 and less than 1. And so here we can also see that our transmission probability parameter, our beta, is going to be modified by the susceptibility parameter psi sub I, or psi sub A and K, our control measures, epsilon, and the contact rate. So you can see this component here. So that's just something to keep in mind. So we have a couple of key measures that we're interested in, of course. So we have our basic reproduction number, which is R naught. Again, it's the average number of secondary cases resulting from one infectious individual being introduced into a fully susceptible population. And when R naught is greater than 1, the disease will persist. And when it's less than 1, it will die out. And we are also interested in determining the control reproduction number, R sub C. And this will be the average number of secondary cases, again, in a susceptible population, but when control measures are applied. So again, the epsilon parameters will fall between 0 and 1, and for either the A population or the K population, or both. So we can use the next generation matrix method to determine our RC here. And so we have our 2x2 matrix, where rho will be the spectral radius or the magnitude of the dominant eigenvalue. And that's, we'll be able to find RC here. And when all epsilon parameters are set as 1, then there are no control measures applied, and RC will reduce to R naught. And this is also, this will occur, R naught will be determined when there's no importation parameter as well, just to note that. So what we're doing is we're looking at three geographic health regions. We're choosing the Calgary health zone, the Greater Toronto area, and the Greater Vancouver area. So these are all urban regions. You can see the population breakdown. So the Calgary health zone has about 34% of the provincial population, and they reported 38% of the provincial confirmed cases up to February 8th, kind of the end of the period that we're looking at in 2021. The Greater Toronto area, we're incorporating 4 public health units, so Peel, York, Toronto, and Durham. This region has about 46% of the provincial population, and they reported 68% of the provincial confirmed cases during this time. And the Greater Vancouver area, we're incorporating Fraser Health Authority and Vancouver Coastal Health Authority, and they're adjacent to each other in the Greater Vancouver area. So, and there's a lot of commuting and population mixing occurring there. This region has about 62% of the provincial population, and they actually reported 82% of the provincial confirmed cases during this period. So this is also a really good example of heterogeneity at a geographical or spatial scale. So here we have some figures of the cases reported by age group in these 3 regions during March 2020 and February 2021. So I'll just describe what's here. So on the left-hand side, the first column is all associated with the Calgary health zone. The Greater Toronto area is in the middle column, and the Greater Vancouver area is on the right-hand side. And so we'll just go through sort of what we have here. So we have some log linear plots of cases of children and youth, which is the blue curve, and adults are the red curve in these 3 regions. So the top row here is just kind of showing the comparison. There's a very small proportion of cases in children and youth in the early phases of the pandemic compared to adults. So this is a good way for us to examine the concurrent growth and reduction of cases in each age group. We can see that the epidemic curves here in this format are roughly parallel in these plots. The disease dynamics in the adults and children and youth are quite closely coupled, and both populations have similar exponential growth rates generally. There are a few differences here at the beginning of the epidemic in the Greater Toronto area and the Greater Vancouver area, where this is potentially due to a greater number of cases in long-term care homes in early 2020, as well as other testing criteria and maybe capacity and things like that. That's sort of what we are assuming is kind of resulting in this difference. So now we'll go to the second and third rows. So the second row is, again, our adult cases in a log linear plot. The colored ribbon behind the case curve here, the epidemic curve, will reflect the periods where non-pharmaceutical interventions, were implemented, strengthened, and relaxed. So these interventions were typically community-wide as well as adult-specific. And so as control measures in each region were relaxed, you can see that the gradient goes from a light green to a dark green, and as they're strengthened, they go from a yellow to a dark red. And just as a note, that the colors here in this row do not reflect the same control measures applied in each region. They only reflect when relaxation and strengthening of control measures occurred according to what had been implemented within that region or province at the time. So again, here we have our third row, and this is our children and youth population and the cases reported over this time. So here we want to take a look at the school-related measures, particularly because they are primarily impacting children and youth. So what we have here, we have four colors. Red will be reflecting the periods when schools were closed. Blue will reflect holidays, so summer holidays, winter holidays. Green is our school reopening with precautions in place. And then yellow is the hybrid measure, where there was some remote school, some at-home learning, things like that. And the dashed line here is the September 2020 school year start. So I'm just bringing the dashed line up to all of these other rows. And so we can see that there's some exponential change at each major control period change. And this will also depend on the type of control measure being implemented in each region. And so we can kind of see as control measures really relax, there starts to be an increase occurring here, like in the Greater Toronto area in the adult and youth, the adult population, as well as in the children and youth population. There's reduced control measures and likely more transmission occurring. So we start to have an increase in cases. And similarly, with the, let's say the Greater Vancouver area, the strengthening of control measures, you can see the decrease in cases reported. And so this coloring kind of allows us to also segment the time frame in question based on the control measures to have a better visual of kind of what's been happening in the background of the cases being reported. So now what we want to do, as I mentioned earlier, we have three parameters that are unknown: our beta transmission probability parameter, as well as our epsilon A and epsilon K parameters. So we're going to do this in multiple steps. So the first step is to estimate the baseline transmission probability, our beta parameter, and we want to do this in the period where there are no control measures implemented to get a baseline transmission rate. So we're using maximum likelihood estimation. And what we do is we are fixing all of the parameters that we know. So we have our parameters from the literature, so our delta, gamma, psi A, and psi K. And we also set our epsilon A and epsilon K parameters to be, we set them as 1 to reflect the absence of control measures. We also have our nu sub A, which is the importation rate, and that is implemented in the Calgary health zone. And the reason for this is that both Greater Toronto and Greater Vancouver area distinguish between imported or travel-related cases and local cases. And so we're really interested in local community transmission. So we're able to isolate the cases that are associated with local transmission and remove the travel-related cases. But in Calgary, the data set doesn't distinguish between those cases. So we've actually had to incorporate an importation parameter in the estimation. So at the date time frame here, because we're looking at the beginning of March when community transmission is starting to occur more frequently, the time period for our estimation is actually quite short, between 10 to 16 days. And so you can see the estimates of the parameters on the right-hand side in the table here. So now that we have our estimated baseline probability, we're going to be using that value in each region. We're going to be fixing that going forward. So that will kind of be the baseline. And we want to see how the epsilon A and epsilon K impact that based on the control measures. So we want to look at the intervention strength. So what we do now, we have a number of subsequent control periods. So in each region or across the regions, we have about 15 to 17 or so different periods. So based on what occurred throughout each period. So going through the Canadian Institute for Health Information, they have a COVID-19 intervention database. And so going through that information as well as news reports and other things, we've determined these control periods that we're going to be looking at the intervention strength. So we fix our parameters again, all of the parameters above, except we don't incorporate the importation parameter anymore, the new sub A, so that's gone because travel restrictions were put in place. We fix our baseline transmission probability, and we are now going to be estimating our epsilon A and K. So as we do this, the end state of each control period is going to be the initial condition for the next period of the SEI classes. And to incorporate even more precision and to account for the latent period, we actually are going to be using the end state less 6 days as the initial condition for the next period to account for potential infection and the delay between infection and the start of transmission when somebody converts from an exposed to an infectious status. So here are the initial results of that process. So we have our parameter estimation results, we have our fitted curve, as well as, again, the colors representing the associated control measure strength. So the top two rows and the order of the columns, again, are Calgary on the left-hand side, Greater Toronto in the middle, and Greater Vancouver on the right-hand side. The top two rows, we're looking at the adult population specifically. So the first row is representing the time-dependent changes in the estimated epsilon A parameters. So the parameter that captures the reduction in transmission probability when interventions are applied. So 1 represents no control and 0 represents very strong control measures. The second row is the fitted curve to the cases in the adult population using these estimates. The colored ribbon in the background, again, reflects the sequential control measure periods in each region when they're implemented and strengthened. And then we also have the dotted line reflecting the fall 2020 school opening. The third and fourth row, similarly to the first two rows, is the child and youth population. So again, the third row, we have the estimated epsilon K parameters over time. And then in the fourth row, we have the fitted curve to the children and youth cases. And the colored ribbon in the background reflects the school-associated measures in terms of opening and closures. So we can see that the curves fit relatively well to the adult data in all three regions in the second row here. However, in the child and youth population, we can see here there's actually not the greatest fit, particularly in the early phase of the pandemic. And this is very obvious in the Greater Toronto area. This is also present in the Calgary Health Zone and the Greater Vancouver area, but you can't really see it at this scale right now. So just the rest of the curve throughout the rest of the period fits fairly well, but there's this overprediction of cases here. So some of the potential reasons for this, what we're thinking about is that testing criteria is very restricted during this time. Only particular populations were prioritized for testing. There were also testing backlogs reported around this time, which may have just reduced testing. So maybe not as many children and youth were able to get tested, but were symptomatic. So they're not reflected in the data. As well, there were also large long-term care home outbreaks in the Greater Toronto area and Greater Vancouver as well. And so there were a lot of testing increases within long-term care homes of residents and staff. So what we suggest, or what we think is happening here, is that the way that the model is set up, using the contact matrix that we have that reflects that represents the mixing between adults and children. The model is kind of expecting that there will be more cases in children and youth than are reported, due to the assumption that there would be more interaction occurring between adults in long-term care home and youth and children. So if there are a lot of cases occurring in long-term care homes, those are being reflected here in the curve, but the model would be expecting that children and youth would be interacting with these individuals, when really that's not the case. There were lots of restrictions, and the mixing between those populations would be very different. So we tested this assumption by removing all the long-term care home cases, associated outbreak cases, from the data set and refit the model. And the overprediction was still present, but it was reduced by about half. So there's likely other factors also being reflected here that we just are not being captured, like testing challenges and things like that. So some notable results here. The estimated parameters here for the epsilons, K or epsilon A at the top and epsilon K on the bottom, is really reflective of the contacts between and within age groups when control measures are applied and relaxed. So epsilon, again, is reflecting the reduction in transmission based on control measures, where one is no control, and as epsilon approaches one, that there's really relaxed measures occurring. So in the first half of the time frame, it's not overly obvious based on the curve of the data. There's some growth, but it's a small scale right now. But we can definitely see that when we look at the control measures, the control parameters, when control measures relax, both the age-specific ones like hybrid school and summer holidays, which is occurring down here with the yellow and blue periods, this is reflected by an increase in the epsilon estimate, so a relaxation, particularly in the children and youth, but this is also shown in the adult population, given other relaxation measures, summer holidays, and things like that. And then after September 2020, you can see that the strengthening of control measures is also reflected in the adult group here. This is shown somewhat in the children and youth population here in the estimates, but because we have the addition of in-person mixing when schools are open, there's a layer of complexity here. So we can see that in the adult population, we know that there was a lot of strengthening occurring. So we do have some a reduction in the estimated epsilon A parameters. And we do have some kind of growth and reduction in the epsilon K parameters. But again, this is also accounting for the within group mixing occurring. So now, by considering these two populations, we've been able to consider the different susceptibility, different behaviors or mixing activities and control measures applied at these various times. So we can isolate the impact of these control measures in each population. And we can also see that there are age-specific control measure effects that affect the other populations. So they're very linked. For example, here on the left-hand side, we have the Calgary winter holidays, just where the ovals are. So we can see here that the estimates increase in both population groups, which may reflect increased mixing between and within both age groups. Of course, this is also dependent on the type of interventions occurring. So I can't quite remember what was happening here, but we do see some increased mixing. So potentially more between group mixing, so between adults and children occurring. In the Greater Toronto Area at the start of the fall 2020 school year here, there's a clear relaxation of control measures in the children and youth population, so down here, and strengthening in the adult population. So you can see that the parameter estimates decrease here and they increase here. So this is kind of around the initial school period closures. And of course, there would likely be other control measures occurring in the adult population here, given the gradient of the control measure ribbon here, the red. So this could also be, these differences could be due to the strengthening of measures in adults, but also reflective of the change in context. So more interactions between children and youth and less interaction between children and adults. So interactions between adults within the adult population may be increased or reduced depending on the control measures applied. So here, like I mentioned, it shows a reduction. And in the Vancouver area, we have a relaxation in both populations in the fall 2020. So you can see the parameters increase, and at the winter break, you can see that the control measures actually strengthen. So there's a reduction in the value, which reflects strengthening, while adult control measures actually relax. There's like a tiny little bit of an increase there. And this could also this is likely due to the changing interaction of adults and children during this time. So of course, you have to note that the selection of timeframes, we've tried to choose them as best as we can. So some of the timeframes may be impacting some of these estimates, or there might be other factors not accounted for here. So there are some interesting kind of dips and peaks here. So it could be due to the timeframe estimates or other outbreaks occurring that we didn't consider. So now what we have our estimated parameters, and we want to consider some alternative scenarios. So we're going to be looking at the fall 2020 peak first here. So what we want to do is we want to vary our control parameters one at a time, and then we'll vary both in different ways. So here we have our black curve. This is our model fit. The gray dots are the reported cases. And so what we're going to do first is to look at the dark blue curve. So this reflects a stronger control measure implementation in the child and youth population. So essentially, we want to reflect school closures in fall 2020. We're keeping all the other estimates the same. And we can see over all of the regions and in both populations, the reduction is actually not quite that significant. When considering the overall fitted curve, the black curve, there's not too much of a reduction. Perhaps in the Greater Vancouver area, it's most affected, but typically it's when looking at the other curves, it's not really that effective. The dark red curve now, we are going to be moderately enhancing adult control measures, so strengthening those control measures by about 20%. It's quite a significant impact on case reduction compared to the dark blue curve. So you can see that it really reduces the peak in all regions and in all populations. So really showing the effectiveness of adult control measures strengthening. And now we want to vary two parameters. So we have our light blue curve here, which reflects schools being closed and moderate strengthening of adult control measures. There's a small reduction beyond the dark red curve, but not really significantly. And this is kind of in all populations. So this really shows that the addition of school closures here does not really make a significant difference when compared to only strengthening adult control measures. And then finally here, the pink curve just reflects the moderate strengthening of both adults and kids by 28%, so leaving schools open, but reducing the control measures a bit. So here it's very similar to that of the dark red curve, and adult strengthening really has the most impact. So taking some of these results, it's really important to also think about the impacts of some of these measures. So school closures, there may be other unintended or other impacts occurring in the population when schools are closed compared to when they're open and things like that. So being able to see some of these variations in potential scenarios is really helpful to kind of see what to compare intervention approaches. So now we look at a second scenario. So we're going to be considering having schools open in the spring of 2020. So all of the schools were closed around this time, with some hybrid opening around June in a couple of places. So here we're going to be considering the joint scenario where we have schools open in the spring and in the fall at various precautionary levels, and with the addition of adult control measures. Strengthening of adult control measures being implemented. So here we have our dark green curve. Schools are open in the spring with no additional precautions. So business as usual, mixing as usual, and we keep the fall scenario as the same as it was in fall 2020 based on our fitted parameters. And so we can see that there's actually a very large increase in the Calgary health zone. There is an increase in the Greater Toronto Area and Greater Vancouver as well, but Calgary definitely has quite a large peak when we consider schools opening in the spring. The red curve, the dark red curve here, reflects having schools open in the spring with additional precautions, so similar to what was occurring in the fall 2020 period. We keep the fall period the same. We can see that precautions in the springtime when schools are open reduce the amount of cases in all regions, but we still get more cases than the scenario, what actually happened in 2020. So our black curve and the data. And then we want to vary two parameters. So the light green curve considers schools being open in the spring, so business as usual, no additional precautions. And here we're adding the additional moderate strengthening of adult control measures in the fall by 20%, and all the other parameters remain the same. So here we can see that there's actually more impact in the Greater Toronto Area. So the light green curve here reduces the cases below the fitted curve. So moderate strengthening of adult control measures in the fall really has a significant impact, even if schools were open in both spring and fall when precautions are applied. And so having precautions in both populations as well as the addition of that is really noticeable here. There is a reduction in the Calgary zone and the Greater Vancouver area, but this scenario still would produce as more or as many cases as the original fitted curve. And then we also have the light pink curve, which considers schools being open in the spring with precautions, similar to what was in the fall. And then we strengthen the adult control measures in the fall by 20% again. And this is the most effective approach in all the regions. The impact of the adult control measure strengthening is quite obvious with the pink curve here across all regions. And I have another scenario, but in the interest of time, I won't go through it very quickly. We do look at the scenario where susceptibility between populations is equivalent, and there are some interesting results here. So we can use this approach to consider other pathogens, for example, like influenza, other ones where transmission is potentially quite different, and susceptibility and infectiousness is different. So this is one way of taking a look into that. So just a couple of conclusions here. So we have seen that a slight increase in adult-specific control measures has a similar and or greater effect on reducing transmission in both populations when compared with a drastic strengthening of control measures in children and youth in fall 2020. And this is consistent across regions, despite the differences in control measures that were applied across regions. We did see that in the scenario where we open schools in spring 2020, There was a very large effect in terms of the epidemic curve resulting from that. So this really shows that closure of schools in spring 2020 has quite a large effect in this region, and this could be due to some more relaxed adult interventions during this time as well. And so another thing that, as I noted earlier, is something that is interesting with this model and the data that we're using is the overprediction of cases, particularly in children and youth. So thinking about the potential reasons for this, testing capacity, priorities, backlogs, long-term care home cases, and potentially acute care cases could be represented there, and also contributing to some of that overprediction. This kind of really reflects and shows the importance and the challenges of the data that we're using to fit our model, particularly in the early phases of an epidemic when there is a lot of uncertainty and there's a lot of really quick measures being implemented, a lot of testing in particular populations. And so this model kind of reflects some of those challenges with the overprediction that we saw. So some of our next steps that we're going to be doing is to incorporate asymptomatic, pre-symptomatic, or undetected transmission to improve the model realism. We also want to incorporate more data to refine the parameter estimation. So right now, the parameters associated with the infectious period or the rate of recovery is pulled from the data. And so, or from the literature, excuse me. So now with the data, what we want to do is look more at the symptom onset and testing dates and kind of the delay between those dates, with the assumption that when individuals get tested, they go into self-isolation and essentially remove themselves from the population and don't contribute to transmission. This would be an assumption, of course, but so this will help to make the model and the fitting process more precise. And so it will be interesting to see how, or if that does change our model predictions later on. We also need to consider more heterogeneity in population mixing. So the contact matrix that we do have is Canadian specific, but it's very general. Because we only have 2 age groups, there's a lot of hidden behaviors and mixing and things like that that are not captured here. So to incorporate more heterogeneity and potentially more regional heterogeneity in terms of population mixing, as well as the impact of imported cases and things like outbreaks in long-term care homes, acute care, need to be considered to refine this model. And like I mentioned, the contact matrix as well, it's currently fixed, but when control measures are implemented, so when there's schools reopening and there's population mixing occurring, the contact matrix will very well likely change over time. And so this is definitely something that needs to be considered. And then finally, we'd like to incorporate spatial patches to represent location-specific mixing and the impact of, and consider, I guess, interventions being applied by location rather than age groups and what that could look like. So that is... My screen is frozen. There we go. So that is the end of my talk. And I just want to acknowledge that this research is supported by all these wonderful funders. And yeah, so thank you for listening to me. And I'm happy to take any questions if there's time.
Thank you, Tanya. Thank you for your informative and personalized talk. I really enjoy about it. And
thank you.
Thank you. Is there any questions or comments? You can raise your hand, or if you're not comfortable, you can write it down in the chat. Okay. I by myself have a question about the contact matrix.
Mm-hmm.
The things that comes to my mind is you consider CKK, CKA between kids and adults, and CAA between adults. Mostly I'm thinking about CKA and CAK. Do you think that this kind of contact matrix will be better for long term? You know, do they have better fitting for long term instead of a short period of time?
Potentially, I guess it kind of depends on, I mean, so the contact matrix is very general. There are definitely more like more specific contact matrices. And so in terms of long term, I think it depends on what kind of changes are happening in the background too. I'm not sure if I'm answering your question, but I think
I think your work is perfect, but I'm thinking about I just feeling about can we say that this kind of contact matrix works well for a long term, not for a short period of time? You know, I was wondering if, as you consider it for the situation of pre-vaccination coverage.
mhm.
Yeah, that
I
is the
think,
thing.
yeah.
Mostly the elements related to CAK and CKA, not the CKK or CAA.
I'm not really sure. I imagine they could be, but I think like with this approach, because it's yeah, I'm actually not really sure how about that. I think if we're doing a fitting process for a longer period, like it maybe, let's say a 3 month, is that sort of what you're thinking rather than really short intervals? I
Yeah.
think there would be a lot of changes occurring. So having it fixed like this, particularly the Ka and Ak contact matrix, likely will not be as I guess useful or like a good way to do that, because over time there would be a lot of changes.
Thank you. Thank you very much.
Thanks.
I think we have another question, Joseph. Yes.
Yeah, thank you, Tanya, for very clear talk. So my question is on why you selected those three regions, like what influenced your choice for the three regions that you used to take data from to work with?
Yeah, that's a great question. I guess I didn't really talk about that. So I originally was working with the Vancouver data, being out in BC. So that was my initial choice for the British Columbia data and having access to the data set. And then I did a bit of looking in the literature to see if there were any regional comparisons between multiple regions, and I didn't see too much, particularly incorporating Calgary. So I did kind of look to see what data was out there. And the reason I chose those three regions is because they are all urban regions. They also do have an international airport. So the initial importation of cases would have kind of been seeded there initially, where a lot of the case growth would have occurred. So I did want to kind of compare those regions as well. I did do a bit of work with Edmonton as well, but because Edmonton and Calgary are quite spread apart, I wanted to kind of limit the assessment, the regional comparison to just a few regions. So I did choose Calgary over Edmonton there.
Yeah, thank you. Yeah, good to know.
Thank you.
Thank you, Tanya, for your talk. We really enjoyed. Thank you, everybody, for attending to the 18th series of OMNI-RÉUNIS. Next week, on 20 and 21st of February, we have annual meeting of OMNI-RÉUNIS. I would be thankful if you are interested to join us via Zoom meeting or in person. Thank you all. And if there is no more question or comments, I think there is no more. We can stop the session. Thank you.
Thank you so much.
Thank you. Have a great one.
Thank you. Thank you.
Bye-bye.